All right. Welcome and thank you for joining. My name is Ashley Lusick, and I am a health educator for community health at Atlantic Health System. Today's webinar is Women and Heart Disease, and it will be presented by Dr. Cindy Cadaspati of Atlantic Medical Group Cardiology at Hackettstown Medical Center. Before we begin, I have a few announcements. This webinar is being recorded. All participants are muted. If you have a question, please use the Q&A for questions or the chat for comments. We will try and get through all questions at the end of today's presentation. Are you or a loved one interested in smoking cessation? Atlantic Health System offers a free quit smoking program. This program includes an individual assessment, free nicotine replacement products, and 6 weekly group meetings to help you quit and stay smoke-free. There are multiple dates and times available, with groups available in person or virtually. For more information about these groups and other resources, or for additional dates and times, please call 1-844-472-8499. The first step to a healthier heart is knowing your risk level for heart disease. Take 2 minutes to complete our online quiz and get your individual results. Finally, before Dr. Cadaspati begins, we'd like everyone to please take a quick poll. I will launch the poll right now for you all. And your answers will be anonymous. I will read these questions aloud as you complete this poll. Heart disease is the leading cause of death for women in the United States and can affect women at any age. True or false? Which of the following are symptoms of heart disease in women? Select all that apply. Dull, heavy chest discomfort or ache, pain in the neck, jaw, or throat, pain in the upper abdomen or back, nausea, vomiting, tiredness that will not go away, or all of the above. And the last question is, identifying heart disease early gives you the best chance of managing it well. Is this true or false? And I'll give that just another moment. We still have some participants answering. Awesome. Thank you all so much for participating. And without any further ado, I am now going to turn things over to Dr. Cadaspati.
Excellent, thank you. I will go ahead and share my screen, Ashley, so let me know if that looks good.
Yes.
Okay, excellent. All right. So good morning, everyone. My name is Dr. Cindy Cadaspati. It is my absolute pleasure to be here today and speak to you on cardiovascular disease in women, something that I definitely address every day in my career. I am the managing physician of Atlantic Medical Group Cardiology in Hackettstown and also in Sparta. And we basically serve the western region of Atlantic. And so prior to that, I should just mention that I had a long military career. I'm actually a retired soldier in the United States Army, retired from the reserves, but served on active duty for over 14 years. So I've had some interesting experiences throughout my career. And actually within the Army, we made it our business after things got better after war to basically focus on prevention in cardiovascular disease. And so it's my pleasure to continue to do that as I serve in a civilian setting. Um, this is a really big topic, so we tried to narrow it down to things we thought you would be interested in and learn from today the best. Obviously, we can speak for hours about this subject, but hopefully you'll learn something today, and I'm hoping that each and every one of you get 100 on the quiz. But here are my objectives. First, I will provide a brief historical perspective with respect to cardiovascular diseases, and then discuss some important facts about women and heart disease. And then we will focus our attention on risk factors for cardiovascular disease, particularly in women. We will shift gears then to speak a little bit about the symptoms, presenting symptoms of heart disease and of heart attack, and in general, those both in general and those unique to women. And then we'll talk a little bit about some special cardiovascular considerations as it pertains to maternal health through menopause, and finally focus the most on prevention of cardiovascular disease. So let's talk about history a little bit. Years ago in the 1930s and 1950s, cardiac disease wasn't really a thing. Medicine didn't focus very much on it because there was so much infectious disease out there, and that was what was killing people. And so the focus was on conquering infectious diseases. And it wasn't until the discovery of penicillin by Alexander Fleming during that time period that we began to get a hold of infectious diseases and be able to treat them more effectively. So we saw less deaths as it pertains to that. Then started to emanate a mounting epidemic of cardiovascular disease in the 1940s and 1950s. The problem is we didn't know how to treat it because we didn't understand much about the disease process. So if you had a heart attack in those days, it looked something like this. Well, lay down in bed, don't move, rest, and hopefully you'll get better. That wasn't obviously very effective. Then in 1948 was the discovery that aspirin was antithrombotic or can work against clot buildup in the arteries. And that was one of the first treatments we had for treating heart attack. And so things began to get a little bit better. But as you can imagine, aspirin alone was definitely not sufficient. So in the 1960s to 2000s, we began to understand a lot more about cardiovascular disease, and we attribute a lot of this to the Framingham Heart Study, Framingham being a town in Massachusetts, where they gathered thousands of people and followed them through years to figure out what are the risk factors for this disease process, understand more about the pathophysiology, and then be able to come up with more effective treatments. And boy, have we come a very long way in the last 70 to 80 years. Um, it actually evolves as we speak. So this was a really, really important study, and it's ongoing actually. So not only did they look at folks during that time, but they continue to follow their descendants. So it's really remarkable how much information and research evolved out of the Framingham Heart Study and how much it has helped us understand cardiovascular diseases. And then in the 2000s, at this moment in time, now we have lots of medications to include statins, which developed in the 1990s to treat cardiovascular disease. And so we began to understand a lot more about it, be able to treat it more effectively. And now the focus starts to shift toward how do we prevent this disease process from ever happening, since it was so paramount. During that time period also, there was a focus or evolving focus on women and heart disease, because in years before that, it was always respected that this was a man's disease. And it became to be realized that that was no longer true. It was emanating in women as well and becoming very, very important, and a major form of morbidity in women and also death. And then also we're starting to focus a little bit more on ethnic disparities. And we have a lot of work to do in this arena, but we certainly know a lot more today than we did 20 or 25 years ago. So the American Heart Association launched its Go Red campaign in 2004. So this year we're celebrating 20 years of this. And I'm very proud to say that I was a cardiology fellow when this campaign launched. And with the help of my mentors, who happened to be, I had some wonderful women mentors at the time who were very, very interested in this. And so even in the Army, we paid a lot of attention to this. And so as many of you may know, February is Heart Month, and the first Friday of every February is Go Red for Women Day. So you will see women across the nation sport their red dresses or red of any sort in their clothing, hopefully, to support this campaign and to raise awareness about heart disease in women. And it is starting to reach international territories as well. So it's a really, really important campaign, and one that I'm proud to say we celebrate in our office every year. So let's talk about some important facts about women and heart disease. First of all, it remains the #1 cause of death in women and more than all malignancies or cancers combined. And even I find that hard to believe it sometimes because it seems like every time you turn around, you're meeting someone who is diagnosed with cancer or has a family member diagnosed with cancer. But it turns out the research shows that it really is cardiovascular disease is the #1 killer of women. Only about 44% of women, however, recognize that cardiovascular disease is their greatest threat. And this is disturbing and comes out of a report in 2019. This is after, 14, 15 years of this campaign being launched. So I still think we have work to do in this area, and why I try every year myself to help provide some information about it and raise awareness in my own little small way. One woman in every 90 seconds suffers from a heart attack. To me, that's a really, really scary fact. Over 400,000 women die every year from heart disease. And cardiovascular disease is also the #1 killer of new moms. So it's not just all women, but even in young new moms who have given birth. Turns out that Black women have some of the highest rates of death in this arena. And so we need to be conscious of that. And it spans across additional cultures as well. We should know that pregnancy-induced hypertension, preeclampsia, and gestational diabetes, which are all potential complications of pregnancy, can increase your risk of cardiovascular disease in your lifetime. So these are important things to be aware of. So some additional important facts about women and heart disease: menopause. So let's get past the maternal years and more toward menopause. Menopause turns out to be basically the point in a woman's life where the cardiovascular risk tends to accelerate, and there may or may not be some associated with changes in hormones. Unfortunately, we see in menopausal women an increased risk of heart attack and stroke during that time period. Most cardiac and stroke events, however, can be prevented, so raising awareness will hopefully lead to that. It turns out that approximately 57% of Black females have high blood pressure. That is a very strong incidence of hypertension in the Black female population. And about 50% or 57% of stroke deaths are in women, not just men. So it turns out that more than half of stroke deaths occur in women and not just men. Women are less likely to receive innocent bystander CPR. That's also concerning. Why is that? Well, research has shown that it's because of a fear of accusation of inappropriate touching or perhaps sexual assault or injury. Folks are so worried about getting criticized for trying to take charge that women tend to have less opportunity at CPR from a bystander than men. And finally, women continue to remain underrepresented in research trials, although I will certainly say that since my training, it has improved significantly. So what are the most common types of cardiovascular disease in women? And I've listed a few here for you. Coronary artery disease, so this pertains to the plumbing of the heart. Arrhythmias, such as atrial fibrillation, disease of the heart valves. So the heart valves over time, depending on risk factors, can become stenotic or close down, so they don't open as well, or they may not close well and leak backwards into the previous chamber if they become diseased. Microvascular disease is also something we recognize in women. Unfortunately, it's very difficult to diagnose, but this pertains to disease of the small vessels of the heart arteries, and is difficult because it's not easy to image always. Next, we have cardiomyopathies, and associated with that is congestive heart failure. What I mean by cardiomyopathy is basically a weakening and or dilation of the heart muscle, so the left ventricle especially may not function as well. There are also the possibilities of congenital heart diseases, so being born with a specific heart problem, such as a hole between the chambers of the heart. And finally, some of you may have heard the term broken heart syndrome. Broken heart syndrome is unfortunately something I've seen frequently throughout my career. It is basically, we see it the most in women over the age of about 55 who have sustained some very, very significant life stressor. Often it is the death of a loved one that happens acutely. And the patient may show up looking like they're having a heart attack, and we may treat it as such until we learn otherwise. What happens in this syndrome is if you do go on to the cardiac catheterization lab to have your heart arteries looked at with the use of contrast dye, we may see that the heart arteries are fine, but the left ventricle is ballooning in a way that it doesn't pump well and can lead to heart failure. The good news about broken heart syndrome is that the prognosis is usually quite excellent and people recover within several weeks of rest and medications. So I'm going to focus the most, actually, let me go back a slide. Wanted to point out, I grayed out coronary artery disease because we will focus the most there today, and that pertains, again, to the plumbing of the heart. And then in pink, you see microvascular disease and broken heart syndrome, because these are known to be mostly diseases of women. So on this slide, this is just a little cartoon depiction of what we're talking about when we talk about coronary artery disease. So over to the left, and actually I learned this morning that I can use a laser pointer, which I'm very excited about. So here you see what a normal artery would look like in a cartoon format. And the little dots are the red blood cells and blood flow going through the vessel in a very healthy artery. Here you see the beginning of cholesterol plaque formation, and plaque starts off as mostly soft and full of cholesterol. And over time, the body will try to heal it so it becomes fibrous or like scar tissue. And it actually ends up being more stabilized in that regard, but can still come into the vessel where it narrows the vessel. And then in more time, that plaque will become hardened and calcified. So that leads into some of the things I will talk about later as coronary calcifications or hardening of the plaque. This picture here shows advanced cholesterol plaque as it starts to accumulate in more areas around the vessel. And interestingly, laws of physiology have it that the artery will actually dilate for a time to accommodate the blood flow going through it. So it is not impaired, but it can only do that so much. And by laws of physics, it will stop dilating at some point and the plaque can start to accumulate further within the lumen of the vessel. And to the extreme right, we have significant plaque buildup and a significant narrowing of the artery that you can appreciate here. And when it gets to this point, and we appreciate it as over about 70 or 75% of the diameter of the vessel, when it takes up that much, then it's likely to form some symptoms like we know as angina. And this is just another picture of similarly looking at heart artery disease, but I wanted you to see what the heart looks like with its arteries that we're talking about. These are the arteries or tiny little vessels that are on average about 3 to 4 millimeters in diameter. So they're quite small, and they supply the blood flow and oxygen to the heart itself. And then here you have one of these vessels, basically, if you were to remove it and slice it longitudinally, looking at the plaque inside the vessel and how it can narrow that vessel and the blood flow going through it. So on this slide, this is actually a picture taken from a patient of mine when I was in the Army, from a cardiac CT angiography study. And these studies are actually quite remarkable and involved many, many years ago now, over 20 years of data on these. But we use them in practice all the time now in the right setting. This is the use of contrast dye on a non-invasive study to look for heart artery disease. And what you see here is this is the left ventricle, again, sliced in half longitudinally. Here is the artery. And you remember from our other picture, the arteries sit on top of the heart and supply blood flow to the heart muscle through tiny little vessels that you can't see here. But with the use of contrast, we can see this tight blockage right in here. I'm sure that's not subtle. This vessel should be bigger and then tapers off as it goes down and supplies tiny little arteries to the muscle. This tight plaque was definitely causing symptoms in my patient, who really was a very, very overall healthy individual who unfortunately had a very low good cholesterol, probably a lot of stress at well in the military. He was a master sergeant in the Army. And he came to me with angina that I was concerned about. He thought everything was going to be fine. We started with this study because in soldiers especially, we need a real definitive answer to get them back in the field. And with this study, we ended up seeing this tight blockage that led to cardiac catheterization, which is an invasive evaluation where we go through the groin or the wrist in the arm to send catheters up to the heart arteries and inject dye into the arteries and take pictures. And here you could see the plaque right up in here, very, very tight blockage. That soldier did end up having a stent and complete relief of his symptoms, and then was, of course, committed to medical therapy going forward to tamp down on the disease process. So how do we assess our risk for heart artery disease? Basically, let's look at first the classic risk factors for heart disease, and I like to break it down into two categories. One category are things that we can change and we have some power over, and the other category is things that we cannot change, that we have no power over. They're within our genetics, within our genetic makeup. So this is another slide that kind of shows this in a little bit more detail. So what you see on the right are the modifiable risk factors in green. So things that we have some ability to manipulate with our own behaviors. And on the left, we see non-modifiable risk factors, things that we cannot change, like our age. Our biological sex, at least, cannot be changed. So if we're born female, with respect to risk, that doesn't change. Genetic factors and some disease entities like high blood pressure and high cholesterol and diabetes do have some genetic component to them. We call them partially heritable diseases. And then, of course, your race and ethnicity. These are things that we cannot really influence. So parents are our parents. We can't give them back. We love them dearly, and they give us the genetics that we have. We cannot change those. We know that family history plays a significant role in one's risk of cardiovascular disease. So knowing that you have a first-degree male, for example, in your family who was less than 55 when discovered to have coronary disease or heart attack, or a female less than 65 years of age, that becomes a risk factor for you, especially in a first-degree relative. Again, we spoke about partially inherited disease processes like high blood pressure, diabetes, and cholesterol. They do have a genetic or can have a genetic component to them. And it's important to know that it's interesting, actually, that over 75% of patients with early coronary disease, when they present younger in life, do have a significant family history. So we take that seriously when we're first meeting patients and obtaining your medical history. But I definitely like to focus on things that we can change. And that is, for instance, smoking, tobacco, nicotine use, nutrition, what we eat each day, our movement, our activity and exercise level, our weight, and then our emotional stressors. I don't come here today saying these things are easy to control or get a hold of, but we have to be cognizant that we do have some ability to influence change here. Let's talk about some special women-specific risk-enhancing factors of cardiovascular disease. So we spoke about classic risk factors, but what do women have that make us even more susceptible to plaque buildup in our heart arteries or other cardiac diseases? So starting with pregnancy, preeclampsia. So preeclampsia is basically the development of high blood pressure during pregnancy, in addition to loss of protein in the urine. The development of diabetes while you're pregnant, so gestational diabetes, pregnancy-induced hypertension. So this is an individual that may not have had high blood pressure before, but we start to see higher blood pressure in pregnancy that may need treatment. Preterm delivery, so if one delivers a baby before 32 weeks gestation, this may be a risk-enhancing factor of cardiovascular disease. And then if you have a child that is born small for gestational age, this can also be enhancing your risk of cardiovascular disease. Does it mean that any one of these things individually will definitely cause a problem with your heart arteries? And the answer is no, but I think we should appreciate that if you have classic risk factors and these additional risk enhancing factors, you should seek preventative screening. So what about later in life? We talk about premature ovarian failure or patients who have early onset menopause. That means specifically the development of menopause less than the age of 40 to 45 years. This can be risk enhancing for you. And so we think it's because of estrogen deprivation as we age. And again, you can see on the picture all the way to the right here, the pink represents estrogen levels in the body. I thought this was a really neat way to look at it. And basically, when you're in your 20s, you have a fair amount of estrogen in your body, and it tends to actually increase in your 30s. But once we hit around the age of 40, and of course, there's some variability between women, we start to have a decline in estrogen levels within our system. And so, with that, we have also seen concomitant increased risk of cardiovascular disease because we believe that estrogen has some benefits with respect to blood flow within those heart arteries, making it healthier blood flow. And then also, it has been shown in laboratory studies that estrogen can actually relax the blood vessels, so lessen the degree of high blood pressure. So when we experience as we age some changes in these sex hormones, what you may see is the development of inflammation in the body. And, especially in the 1990s, we began to appreciate that inflammation was a big, big part of plaque buildup and injury to the inside lining of the vessel walls, especially of the heart arteries. So this can lead to increased risk of plaque sticking to those injured areas. We also know that these changes in sex hormones can lead to increased levels of bad cholesterol in the bloodstream, and specifically LDL cholesterol or low density lipoprotein and triglycerides. And then finally, these changes in sex hormones can lead to lowering of the good cholesterol, the HDL, high density lipoprotein. So, breast cancer is also now respected as a rinse enhancing factor. Again, it's not that breast cancer completely equals you will have coronary disease, but we know that some of the treatments that women go through for breast cancer to include the use of anthracyclines, right? Like Adriamycin, for example, can lead to increased risk of heart disease and actually specifically cardiomyopathy, or again, the weakening of the left ventricle, which can cause heart failure. So it is very well practiced as, in oncology today that patients who are undergoing those, Ashley, can you still see my picture? Because there was a change on my screen here. I just want to make sure you can still see it.
Yes, you can.
Okay, great. Thank you. Okay. So anyway, also radiation to the left chest. This has gotten significantly improved over the years in terms of radiation causing damage to the heart arteries. Specifically, what happens is we tend to see with radiation treatment, especially of many, many years ago or decades ago, where it was more generalized radiation, we can see increased risk of coronary calcifications in the heart. But this is getting better with time as they improve the treatments with XRT or radiation. And so that is why we pay attention to breast cancer and the fact that it enhances your risk of having cardiac disease. And then finally, inflammatory disorders that tend to be more common in women than in men. And these include rheumatoid arthritis, psoriasis, or even more importantly, psoriatic arthritis, and then systemic lupus erythematosus. And I definitely think I see a lot of patients with these disease entities, so I do think there is increased awareness about this. And I'm seeing more and more primary care physicians or patients themselves seeking cardiac preventative measures because they have these diseases and also other classic risk factors of heart disease. There's a high prevalence of these diseases in women, and so we need to attend to them. And then interestingly, this is on a positive note, is that breastfeeding not only has important implications for the child, and I think we all know about those, but it turns out that there are some cardiovascular benefits for the mom. And we think they're related to the fact that lactation is associated with lower maternal risk because of decreased insulin resistance, improvement in your cholesterol numbers, and a decrease in accumulation of fat during pregnancy. If you have breastfed before, you may have realized that the fat accumulation that you may incur during pregnancy can actually decrease significantly when you're breastfeeding, and it tends to go away a lot more quickly. But there are definitely more studies needed in this realm. So let's shift gears to symptoms. What are the symptoms of heart attack? And I know a lot of you know these. Pay a lot of attention to this slide because as you remember, there'll be some questions on it at the end. Um, Chest pain, right? Chest pain can come in a lot of different forms though. It can feel like heaviness. It can feel like pressure, tightness around the chest, squeezing or burning. Some folks will come in saying, I feel like an elephant is sitting on my chest. It may radiate. This chest discomfort may radiate into the shoulders or arm, straight through to the back, into the neck, or even into the jaw. Certainly when these symptoms come on, whether in the setting of a heart attack or warning signs for heart attack, they should be worse with exertional activity and typically get better at rest until it is culminating in a heart attack. That pain can travel down both your upper extremities and it can cause concomitant shortness of breath. But there are some other unusual symptoms that we'll discuss, and those unusual symptoms seem to be more prevalent in women. So I think a lot of times when women go to the emergency department and those symptoms are heard, the providers may not hone in right away that this could be heart related. Again, this is especially true decades past, but I think we've gotten much, much better in accepting that we have to recognize that heart disease is the #1 killer of women and cause of heart attack in women as well. So these symptoms that can be a little bit more vague include just shortness of breath, but typically associated with some chest pressure as well, not always. Nausea and vomiting, neck or jaw pain, dizziness and lightheadedness, pain sometimes in the lower chest or abdomen, and then extreme fatigue. Typically, you wouldn't see any of these one symptoms alone, but it's possible. Nothing is mutually exclusive, unfortunately. So, how do we diagnose cardiac disease? If you go to see a cardiologist because you're concerned of these symptoms, what do we do? Well, obviously, our fifth or sixth vital sign, so to speak, is our EKG. So, an EKG is extremely important. An EKG is depicted right here, and it's basically an electrical representation of your heart, right? So, we can't figure out everything from an EKG, but it can certainly hone us in on clues that may suggest that an individual patient has structural heart disease or potentially lack of blood flow to the heart or some electrical abnormality that can come from blocked arteries. So an EKG is extremely important and has no risk to the patient. A lot of you know about stress testing. You may have had stress testing before. Stress testing, especially in 2024, comes in a variety of flavors, but obviously the most common use of a stress test is either a plain walking treadmill test, where an individual, if able, will walk on a treadmill that goes up in incline and its speed every 3 minutes in general. We use a certain protocol. And I love it when my patients say, you sped that thing up so fast. And I tell them, no, it's really a protocol. We do the same thing for all patients usually. So in any case, what we're looking for during that time is, with rising heart rate, are we inducing any of the symptoms that you were concerned about? Does it cause any stress or strain on your EKG? And we're watching your blood pressures through every stage of exercise. So it gives us an idea of your risk of having a heart attack in the next 1 to 2 years. Stress tests may or may not come with imaging modality, and a lot of that has to do with the number of risk factors you may have or our suspicion that you could have heart disease. Of course, we have to succumb somewhat to the insurance companies and what they'll pay for, but obviously if we have a good case to do a stress test with imaging, we're going to try that for you up front. Echocardiography. Echocardiography is ultrasound. I put in a little picture here so you can see a picture of what we do when we perform echocardiography on patients. This is one of the pictures that we see of the 4 chambers of the heart. And in medicine, we like to make everything a little bit more challenging. So what you'll see is that your heart is actually upside down and inverted here, because that's how we're able to do Doppler interrogation, looking at speed of red blood cells through your heart with Doppler. Echocardiography in general has no real risk to the patient, but gives us a wealth of information about your chamber sizes and how thick the heart is and your valves and how well your heart is pumping. And then we shift gears to CT, computerized tomography of the heart arteries. And I showed you a picture of that earlier. And there are 2 different types within cardiology, one where We don't use dye, and it has very little radiation involved in it. It is a CT coronary calcium score that can detect that old calcified plaque I was talking about earlier. That is used for risk stratification and tells us about what is your risk of having a heart attack in the next 10 years. We can use that information in conjunction with looking at traditional risk factors and risk enhancing factors to help us figure out how to treat. And then, of course, cardiac CT angiography adds contrast dye, so we can more definitively look for blockages. This is a much more expensive test, probably 10 to 12 times as expensive as a CT coronary calcium score, and requires a bit more radiation exposure. Cardiac MRI, that is something that is not done seemingly the first time you meet a patient. This is a little more specialized study, but can be used for structural heart disease and is definitely a more sensitive test perhaps than echocardiography. But in certain scenarios, we do need to lean on cardiac MRI in addition to echo. And then finally, our gold standard for heart artery disease remains cardiac angiography. So this is when we go in invasively through the body. Again, it is even more popular these days to go through the small artery in the wrist, where we can run the catheter through the arm to the heart, inject dye, and look for blockages with the intention to treat them if we see them. So this is cardiac angiography. So next slide is goals for coronary disease prevention. And so conscious of time, I want to focus my time here because obviously in these most recent years, especially the last 20 years of the turn of the century, we're focusing on prevention, right? We don't want to just fix things when they're broken, but how can we prevent us ever getting there? It is not only to reduce the risk of burden of heart-related illnesses and deaths in our country, but also it's actually very costly to treat these diseases. So trying to prevent them is extremely important for a variety of reasons, and we use evidence-based guidance and research to do that. And so really the key to success here is intervening early before a patient even starts to develop symptoms of the disease. So to me, this begins with an awareness, and that's why we're here today, is to raise awareness that cardiovascular disease is the #1 killer of women as well as men in our country and in Western societies in general. And it's important to know your individual risks of having a heart attack. So we spoke a lot about risk factors today. So think about those yourself. And if you haven't already spoke with your primary provider about it or engaged with a cardiologist, it may be time to do that. But it continues, right? The prevention of cardiovascular disease continues with being attentive to those risk factors and actually choosing heart healthy behaviors. So I like to think of prevention of cardiac disease as beginning with our children, right? So if we intervene early, we teach healthy behaviors early. You know, it's not easy, right? It's not easy to teach a child to eat vegetables all the time, but if it becomes a part of their daily life as soon as they transition from lactation or breastfeeding to baby food to real foods, introducing those healthy food groups early and emphasizing them will not only help the child, but it will help you, right? So I really, really am, press that upon you is to start early with our children and grandchildren. And so I like this picture a lot, and I think it breaks down very nicely. This comes from the American Heart Association, who talks about life's 8 essentials, right? What are the essential 8 things we should be doing to stay healthy and to assess our risk of heart disease? So starting with the top here is choosing healthy food groups, movement or exercise, monitoring your sugar through your primary medical provider, or if you already have diabetes, there's lots of ways to do that at home with fingerstick blood glucose levels and all these new devices that you have now available to you to monitor your glucose levels, monitoring weight and keeping your body mass index down. A normal body mass index is respected as around 20 to 25. And what I mean by BMI is your weight in relationship to your height. Knowing what your cholesterol numbers are, at least on an annual basis, perhaps as an adult, and following those and treating them when it's appropriate with the assistance of your providers. Knowing what your blood pressure is. If you have high blood pressure, consider buying a blood pressure cuff to use at home, a good accurate machine to use at home so you can periodically measure your blood pressures and make sure they're controlled. Avoiding any forms of tobacco or nicotine. Getting adequate sleep, which is also, very difficult, especially if you are a working individual. And so these are a nice way to break it down. If we attend to all of these, this will certainly influence your risk of cardiovascular disease. So let's talk about smoking, right? I have patients come to me every day. I completely respect that smoking is an extremely difficult thing to stop. It is very, very highly addictive, but so incredibly damaging that I spend a lot of my time talking to patients about reduction or elimination of tobacco and nicotine use. And so though oftentimes folks will say to me, at least if I vape, that's better than smoking, right? And the truth is, we really don't think so. Any form of inhaled nicotine is dangerous. And so I just wanted to outline why. Inhaled nicotine can cause injury to your vessel, and it does so through damage of the inner lining of the vessel wall, which is really, really tender. It's called the intima. And nicotine is one of those things, in addition to anything that can cause inflammation in the body, that can damage that inner lining. And the body is very smart, very, very smart, right? So basically, it will attack that injury and start to heal it with platelets. The problem with that is platelets are sticky, and cholesterol and other things stick to platelets to form that plaque buildup in the heart arteries, taking us back to those first pictures we saw of damage to the plumbing of the heart arteries. So, in addition to all of these things, there's no doubt that nicotine increases the risk of clotting in the vessels and reduces the delivery of oxygen. So once you damage the inner lining of the vessel, it cannot move blood flow or pump as well. And so with that, you have decreased blood flow to the end organ, being the heart in this case, where when you need more delivery of oxygen and blood flow, when you're exercising, it's lacking. So it's extremely important to avoid any forms of nicotine or tobacco. So these are highlights from the 2021 ACC guidance on diet. So now we'll talk a lot about food because it's my favorite thing with an Italian heritage. But I like to call it, rather than dietary guidance, let's talk about food choices. There's something about the word diet that can have such a negative connotation for people and really cause stress. So it's more about food choices, how we choose what we eat. So it's important to know that, I have a lot of patients. I said it to myself as I turned in my 40s and 50s, why is it that I'm eating the same, exercising about the same, yet the weight comes on a lot faster? Well, it turns out that our metabolic needs decrease gradually with each decade of life, so that we should be reducing our calorie intake by about 70 to 100 calories per day with each decade of life. So to me, that was pretty eye-opening, and I thought that was helpful to share with you. We really should consume a diet that is rich in fruits and vegetables. Okay, so really focusing in on plants and what they offer us, trying to get protein sources from your plants, such as legumes or beans, if you're able to eat those, nuts, if you're able to eat them. Some people are allergic to nuts, so that's fine. You have to add more of the other proteins then that wouldn't be nut based. So if not vegetables, or if you're not getting enough in your vegetables, I certainly promote the vegetables. Look toward fish and seafoods, but seafoods that aren't super high in cholesterol. So you should try to eat probably at least 2 fish meals per week. And we don't want to be frying the fish because that kind of negates the whole point of the health benefits of the fish. So if you're going to consume dairy, make it low fat or fat-free dairy products. You can get protein from dairy as well. And then if you do eat meat, if you're not a vegetarian, try to focus on the white meats. So the white meats are the chickens and the turkeys specifically. People ask about pork. Pork is generally respected as a red meat. So you want to reduce the amount of red meat intake in your diet significantly, and that includes beef and pork. And in addition to that, the big picture of avoiding processed foods, which takes me to the next slide, the concept of whole foods, right? There's so many different quote unquote diets out there that you can do, but I like to really try to simplify it for patients. Work toward eating whole foods the most. So basically, when you go to the supermarket, ShopRite, what have you, I say ShopRite because it's right here in our plaza, but you want to spend the most time in the vegetable and fruit aisle. That's where you want to spend the most time and fill up your cart with those fruits and vegetables, right? And you want to focus on, look, let's face it, as a working mom myself, it is very difficult because it takes time to prepare these foods. But sometimes I think about taking a Sunday, if I can carve out an hour or two to food prep for the week a bit, I tend to notice that we eat healthier that way. That's one thing to think about. But basically, trying to minimize the processed foods, the foods that come from cans and boxes or have some pre-processing, with them. You want to minimize those as much as possible. Eat things from the shelf whole or really from the farm whole that hasn't been manipulated, that you're then flavoring to your cultural desires. So let's talk about exercise. It's really interesting that there's actually a lot of talk about different exercises out there and what we can do. What I want to focus on today is that the aerobic exercise is still shown to be most beneficial to your heart, and so you want to aim for, to keep it simple, at least 150 minutes a week. Per week, 150 minutes of moderate intensity activities. So these are things like a fast walk or a light jog or a light bike ride, things like that. Now, certainly as you increase the intensity of your exercise, so if you're doing things like CrossFit, you can get away with less. And the American Heart Association has lots of resources about this, okay? So I found this as well, and I was happy to see that the American College of Sports Medicine agrees, and the Centers for Disease Control all agree with the American Heart Association that 150 minutes a week is best of moderate intensity aerobic activity. And then I also wanted to point out, and I'm trying to become smarter about telling my patients this as well, especially as we age as females, there's that susceptibility to bone loss. So you want to incorporate some strength training activities as well, at least a couple of times a week, and strength training activities that are appropriate for whatever musculoskeletal issues you may have going on within your body. So I found this to be a very remarkable slide about weight. There's so much stigma about weight, and I want my patients to realize that it has nothing to do with stigma. It has everything to do with health when you come through the doors of our practice. We talk about weight in terms of your health and your risk of cardiovascular disease and why it's so important. And again, another very eye-opening slide put out by The Lancet, which is a very well-respected journal within medicine, in 2016, shows very, very elegantly that keeping a body mass index here of 20 to 25 will certainly lower mortality or risk of death. Once you increase your body mass index to 40 or higher, the chance of dying is twice as much as somebody whose body mass index is down in here. So to me, that was eye-opening. It's also important to know that if your body weight is too low, this can be a risk for you as well. So this here shows you, there's so many ways to reduce weight, right? There's diets, there's pills, there's exercise. What do I do, doc? How do I fix this? Well, doing a little bit of everything is obviously going to be best. But if you wanted to find out what was going to give you the most bang for your buck, so to speak, what is going to reduce your weight the most, it's going to be these top two things here: exercise and eating less. Basically, in general, if you move more and consume less calories, you should lose weight. Okay? So this, when you think about it that simply, I think it tends to be less overwhelming. But certainly, all of the things we talk about to become heart healthy, if you do a lot of all of those things to the best of your ability, that's going to give you the best chance of reducing risk. Blood pressure, extremely important, right? It's important to monitor your blood pressure as you age. Postmenopausal, we have increased risk of having hypertension, and you have to look at your genetic factors as well, how much it is present in your family, first-degree relatives especially. So a normal blood pressure truly is less than 120/80, and that is what is respected today. So as it starts to raise higher than that, and it does so consistently, it needs to be attended to and treated. Cholesterol. We'll talk a little bit more about cholesterol. Cholesterol is one of those things that gets people really excited and anxious at times. Most people don't want to be on statins, and there's all these stigma about statins. What I implore you do is to know your lipid numbers, to work with your primary care physicians. If you have risk factors for heart disease, work closely with your cardiologists. It is very important to manage cholesterol, but not everybody has to treat their cholesterol early. According to the American College of Cardiology, they have supplied us with tools we use to assess your risk, and depending on how high that risk is, we may or may not recommend pharmaceutical treatments for it. It's most important to manage your cholesterol in natural ways first, and I definitely support that. I definitely want to share with you a slide on mental health and coronary heart disease. Such an important part of risk enhancing factors for heart disease in women. Please attend to your mental health issues, right? Keeping healthy mentally and psychologically are so important to your physiological well-being. So there are certain mental health disorders, specifically depression, anxiety, emotional stressors, PTSD. When you have these over long periods of time, they can certainly lead to physiological changes in your body that can put you at risk. These changes include increase in blood pressure, an increase in heart rate, reduced blood flow to the heart with that, and then increased cortisol levels, which I think a lot of women are becoming more cognizant of. When you have increased cortisol in your body, it can cause that feeling of fatigue and depression, and also weight gain. So reduce stress in your life. Again, not easy, very difficult, but just being aware that you need to reduce stress to keep healthy, I think is important. Do what you can do to minimize stress within your own life. It could be consideration of yoga. It could be speaking with a psychologist or friends. Or for me, getting outside in the fresh air and exercising outside, in touch with nature, I think has a very strong ability to reduce stress in your life. So find ways that work for you best to reduce stress as part of your cardiovascular health. And so to summarize, and I think we still have a few minutes for questions, which I certainly want to leave. In summary, heart disease is the #1 killer of women today, as well as men. And I'm very happy to be a small part of raising awareness in our community about that. We want you to be cognizant and familiar of your own risk factors for heart disease. We want you to be familiar with symptoms that are related to heart disease so that you can find out for yourself if it's something that you need to pursue and seek medical attention for. And we want you to adopt healthy habits and adhere to them, stick with them to the best of your ability, even if it's 85 to 90% of the time. So I want to end though in saying that we must raise awareness, but not fear, right? We don't want you to be fearful because you have risk factors of heart disease. There's so much stress and anxiety in the world as it is. Instead, I want you to take that concern, but translate it into healthy behaviors like exercise and eating healthy. Take that energy away from fear and anxiety over the situation, but plug it into adopting healthy behaviors. And so I want to thank you all for this awesome opportunity to share a little bit of knowledge about cardiovascular disease in women. I hope that I have kind of enabled you to seek awareness within yourself, but also raise awareness with your family members, your loved ones, your friends. I'm sharing with you a picture of my amazing staff. I'm missing a couple people on this picture, and I'm also sad that we had to take it with a mask on, but unfortunately COVID levels were high that time and we were still under the mask mandate. But this is my wonderful staff, and we every February recognize heart disease in women and celebrate Heart Month and Go Red for Women Day. And then finally, I couldn't end without sharing my beautiful family with you who support me through my career and my passions. And basically, this is us doing what we love to do best, which is travel. We were stuck in London airport, not a bad place to be stuck, but coming back from a wonderful trip to Germany where we got to visit where we were stationed for 4 years while in the military. So they've been a very huge part about my career and my passion for cardiovascular disease and cardiovascular disease in women. So with that, I'll end and I'll turn it over to Ashley for any questions.
Awesome. Thank you so much, Dr. Kadaspati.
Thank you.
So at this point, I will be opening the Q&A while you're typing in your questions there. I also have our post-test poll. So I'll go ahead and launch that now.
Hope you
So yes, thank you all for joining us. We kindly ask that you take a few minutes after today's webinar to complete the program survey. The link to that survey has been added to the chat for your convenience. A special thank you to Dr. Kadaspati
You're very
for
welcome.
dedicating your time and expertise today. And if anyone has additional questions or comments that we didn't get to, you can send an email to communityhealth@atlantichealth.org or call 1-844-472-8499. That concludes today's webinar, and I hope everybody has a great day.
You too. Thank you, Ashley, and thank you all.
Thank
Have a
you.
wonderful day.